So, welcome to the Department of Cardiology, PGH Chandigarh. We do have a interesting case. He's a 82-year-old hypertensive, non-diabetic, non-smoker male presented with COAD, obstructive sleep apnea. He's having a dyspnea on exertion and angina on exertion and also at rest from last 1 month. 12 years back, he had a PCI to LAD and left circumflex in March 2011 at our institute. The clinical examination showed the normal CVS, there is bilateral basal crepitations, there is a night dip in the oxygen saturation because of the obstructive sleep apnea, which do improve with the oxygen supplementation and also the diuretics. His ECG showed the QS pattern in V1 to V3. Echo showed the ejection fraction of 35% with the LV apical hypokinesia. Serum creatinine and total leukocyte count is within normal limit. This is the echocardiogram in apical 4 and 5 chamber view, which showed apical hypokinesia, EF of around 35%, no mitral regurgitation, no aortic regurgitation. This is the coronary angiography, which was done on 2nd of March this month, showed the dominant left circumflex with the distal left circumflex, the patent is stent, and then there is a diffuse disease in stent restenosis of proximal to mid LAD having a 95% stenosis. Distally, it's a bifurcation lesion. LAD and D2, which seems to be disease-free. RCA mid 100% stenosis, which is non-dominant vessel. Because of the respiratory distress and the gross failure, PCI was not done, and he was again taken after 3 days following the stabilization for the PCI on 6th of March this month. This is the old angiogram of the March 2011, 12 year back, which has very well shown that there is a distal LCX and the OM2 disease, LAD from proximal to distal LAD, which is diffuse disease. Ejection fraction is 60% and RCA, which is non-dominant, had now mid cutoff. At that moment of time, it's the PCI to LAD and the LCX was done. The proximal to mid LAD was treated with the two overlapping Cypher stent, 3.523 in the proximal and 3 into 28 in the mid LAD, while the distal LCX had a 3.523 millimeter Cypher stent and the POBA 2 OM2 was done. Regarding the follow-up, he had a regular follow-up for next 3 years after 2011, and thereafter, as he remained asymptomatic, lost to an follow-up, and now he presented again with the rest angina and left ventricular failure, and also the respiratory distress because of the obstructive sleep apnea. And here we are with the left circumflex, which is dominant and patent with good flowing across it, and the LAD do have around 90% in stent restenosis. You can very well appreciate a mid part of the LAD, which is having a non-stented segment, is having a tight stenosis. And this is what the diffuse in-stent stenosis, the LAD, which we are dealing with. And you can very well appreciate a aneurysm, which is there at the distal part. I'm not sure what the site of the origin of this distal aneurysm. This is what we are dealing with before the origin of the diagonal. It seems there is the aneurysm with some dye staining distally. So here we could cross the wire across the LAD. Next view. And we dilated with 2.5 millimeter balloon. You can very well appreciate the aneurysm over here. This is the wire across the diagonal. We try to dilate the diagonal as well. But then there was some difficulty in pushing because of the intermingling of the two wires, and then we removed the wire, and at this moment of time this diagonal wire, this is cyan blue, is there in the aneurysmal segment. At this moment we had an OCT done after having a LAD in-stent restenosis, which has been dilated with 2.5 millimeter balloon. So here you can appreciate the distal LAD, which is having some calcification, and it's a diffuse in-stent restenosis, mainly fibrotic. A part of calcium is there in between, and aneurysmal segment was there, which been passed off, and here we are. So it's a calcific LAD with a diffuse in-stent restenosis, mainly fibrosis. and the proximal LED is also been calcified, and the mid LED of course do have now an aneurysmal segment. What's the etiology of this aneurysm can be very well discussed among the panelists, and for the timing let me go ahead and dilate the instant restorative segment with the 2.75 millimeter cutting balloon. We do have a reference vessel distally of 3 millimeter, and this is the cutting balloon of 2.75 which we are going ahead for. There is some difficulty, but then we do have an EBU guide over here with us, so could able to push the cutting balloon across it, and this is the stented segment. Inflate 6, 8, 10, 12, 13, negative, go gradual, 6, 8, 10, 12, 14, negative, epicaudal please, 10, 12, 14, 18, negative. So we do have LED which is of 4 millimeter. Approximately 3 millimeter is the distal part, and we are dealing with this aneurysmal segment. Epicranial, please. So our diagonal is flowing very well. Let me try to put another wire across the diagonal in case I am able to push it. Patient is hemodynamically stable. We have started with minimal dose of inotropic support, as he was having a blood pressure at around 90 when taken on the table. So this is what this diagonal is originating from the aneurysmal segment. There is the origin of the diagonal which is there from the aneurysmal segment. And now the question is how to treat this instant restenosis along with the aneurysm across the LAD. So let me have a run of the OCT after having a cutting balloon dilatation across the LAD. See, distal the stent, there is again the calcification. So this is what we have certain cut across the LAD following the cutting balloon inflation. Had some luminal gain across it after the dilatation with the cutting balloon. And let's go ahead for the stenting. And give the 2.75 cutting balloon again, please. So this is cutting balloon which we are going to get it dilated distal part of the LAD, and let's dilate it 6, 8, 10, 12, 14, 18, negative. So this is 2.7510 which has been inflated distally in unstented segment, negative. For the calcified native vessel disease, distal to the stent, the vessel size is how much? 2.9 something. So let me go ahead and put a stent of say 2.75 distally and then decide about. So give me 2.75 33 giants. So it's a 2.75 33. We are trying to push it across the distal LAD, and there is no difficulty in pushing the stent across. You can now very well appreciate the aneurysmal segment, which is well appreciated over here. And to avoid the double layer of the stent, let me push it somewhat further, and let's see. So this is what negative. Inflate 8, 10, 12, negative. Inflate 12, negative. Epicaudal. So proximally the vessel size is how much? 4, sir. And then just at the aneurysmal segment, how much? 3. So let me give 3.538 giants. Epicranial, please. So here we are across the previously deployed stent, and this is well positioned. So let me deploy it. Stop. negative, and inflate. So this is 3.5, 38 giants across the stented segment, 8, 10, 11, okay, negative. So this is what we have achieved across the mid LAD. Epicaudal please. And as the proximally the vessel size is how much? 4. So let me go ahead and put another stent of say 4 millimeter, 423 giants. See, his count during this admission is around 9,000. No fever. So regarding the etiology, the aneurysm, it's not infective. Cypher, the first generation drug eluting stent, is known for the aneurysm formation. Later on, the long-term follow-up and the possibly it's a Cypher-induced late aneurysm of the mid LAD which is there. Of course, it's not the infective one. I think this is good. So let me deploy the 4 millimeter stent over here. Stop. Negative. Inflate. 8, 10, 11, 12, negative. So this is what, and then now epicranial. This is what we have achieved after putting the stent across. Let me post dilate it. 3 millimeter NC. See, one good thing is the diagonal is flowing well. So we are going to dilate the distal LAD stented segment with the 3 millimeter RV. Can you have a stent boost please? We are somewhat outside, so let me pull it back somewhat and go ahead. Inflate 6, 8, 10, 12, 15, 18, negative, 10, 12, 14, 18, negative. So it's a 3 millimeter which we have inflated at 18 atmosphere across the overlap segment of 3.5 in the mid LAD and 2.75 distally. And let me dilate it further with 3.5 millimeter balloon just at the origin of the diagonal, and then proximally followed by say 4 millimeter NC balloon in the proximal segment. So kindly give me 3.5. So distal 5 mm of the previously deployed stent is of 3 millimeter, and rest of the proximal segment is of 3.5. So let me dilate from that particular point proximally. So this is what the previously deployed segment, and let's dilate it. 6, 8, 10, 12, 15, negative. 8, 10, 12, 14, 18, 20, negative please. Patient is tolerating the procedure very well. Blood pressure just now is 134 on minimal dose of inotropy support. Let's see what the status of aneurysm by now after having a dilatation. Can you have a somewhat areocranial please? So here is the aneurysm, and let me dilate somewhat more proximal. So go, inflate. 6, 8, 10, 12, 15, negative. Epicaudal, we are within the stent. Let's go ahead, inflate. 10, 12, 14, 18, negative please. Can you put a stent boost across it? Okay, we are within the stent. Go ahead. 12, 12, 14, 14, 18, negative. So we have post dilated the stented segment with 3 millimeter balloon distally for a reference vessel which is of 2.9, and then it's a 3.5 proximally from the origin of the diagonal, and then from the aneurysmal segment it's 4 millimeter, hence we are dilated with a 4 millimeter. And let's see what the result is, and meanwhile let's concentrate on what next to be done for this aneurysm. So give some NTG, blood pressure is fine. So this is what an epicranial. In this particular view, you can very well appreciate the OM or distal LCX stent. There is some aneurysm at that particular point as well. So this is a classical example of, say, late aneurysm formation in first generation drug eluting stent. That's the Cypher. Epicranial. See, the diagonal is flowing well. I personally feel we can leave this aneurysm at this moment of time and have a close follow-up to look for how it's going to progress. There is some difficulty in pushing the OCT catheter across the stented segment, but ultimately we are able to push it. And we are now distal to the distal LAD stented segment. Are we seeing the good flow across the LAD? So a second run is required to complete the study, and let me have the second run in the proximal to the ostial LAD as well. Okay, we have the appropriate quality of the OCT imaging across the stented segment, and let's analyze it. Meanwhile, let me have few more views to look for angiography. Are we okay or not? This is the spider, and we are okay. So are we okay distal to the stent? No as dissection, that's nice. Mm-hmm. Okay. And this is the segment which we are dilated with 3 millimeter NC. Okay. Can you stop where we are going to have the aneurysm? So this is okay, and now it's a 3.5 millimeter stent, and this is the aneurysmal segment. Yeah, this is what the aneurysmal segment is, and this is the proximal part which is well dilated, expanded, and well opposed segment. Second run, and the expansion is how much percentage in the distal to mid LAD? So more than 90 is the one which is very well acceptable, and this is the run across the proximal to the ostial LAD, which was with the 3.5 dilated with the 4. Proximally it's a 4, and this is the overlap segment. And this is the left main. So we do have a perfect optimization across the whole of the LAD, with a good result. So here I want to stop without doing anything actively for this aneurysm. Let me have the regular follow-up of this patient. A follow-up CT angio can very well demonstrate the size of this aneurysm and also flow across the diagonal. If required, a graft stent can be put at this particular segment during the follow-up. So thanks for being with us, and comment are invited. Thank you very much.